Hi, everybody. I'm Dr. Sharon Clark. I'm a psychologist at the IWK in the Mental Health and Addictions Program. And my role is as advanced practice leader for CAPA, which is the Choice and Partnership Approach. And it's kind of exciting to be doing this orientation virtually. So I hope you'll join with me and I will share some PowerPoint slides and talk you through the history of CAPA at the IWK and kind of orient you to what that whole system of care is about, how we're using it in our system. So I'm going to make the switch now to PowerPoint. So CAPA is, as I just mentioned, stands for the Choice and Partnership Approach. And the thing that I'm really interested in talking about from an orientation perspective is thinking about how we're using this model to create a system of care across our services within the Mental Health and Addictions Program. CAPA is a system flow management tool. So what does that really mean? It means that the two developers, who are two psychiatrists from the UK, developed a model that they feel like helps systems understand all the different pieces that go together to make it work really well. It's particularly oriented for child and adolescent mental health services. However, services across Australia and New Zealand use it within their adult system. And it's designed in a way which I think about kind of brings family-centered care to life. So it's thinking about how we make processes for accessing care to be user-friendly, to be client and family focused, accessible. So when we have really long wait times or people have to figure out complicated ways to get into systems, then they're not accessible. So CAPA is really thinking about what's it like for that family to be seeking care and how do we make it be as effective and safe as possible and make it be user-friendly for them. And after our strategic plan development in 2011, CAPA was chosen as our model of service delivery. And we started with our 3 outpatient teams who at that time were struggling with very long wait times. And it led us down this journey of really rethinking how we deliver services in our outpatients and now thinking much more about how do we use a similar kind of model across all services in our intensive services and thinking about our shared experience of what it's like for families to access our care. Part of the thing that I love about CAPA is that provided us with an opportunity to learn so much from other places. So this is an example of different teams in different areas around the world that use CAPA. And that we've got there's sites in New Zealand, across that country. Ireland, I just recently talked to some people in Northern Ireland. There's a Norway site that started about 2 years ago, and they've been doing some really interesting things and have won awards for their use of CAPA. Dr. Anne York, who is one of the developers of CAPA, is in London. And she's just an amazing resource for us and is very inspiring. And I think what happens with the network is we're able to use this as a knowledge exchange. And I benefit, for instance, greatly from my contacts with a colleague in Auckland, New Zealand, who really understands this model well and has guided us through thinking through lots of different things. So it's provided us with an opportunity to share our experiences. We've helped them learn about how we've been using job planning in a different way. And those are things that they're using now. So I think the more we share, the better we get together. CAP is about how we place the needs of families at the center of our services. So what that requires is us to kind of step back from clinicians or staff experience of being experts with power. And maybe we all think, that's not really my stance. But it really can be experienced like that for families if we don't think much more purposefully about how we kind of show up in the room and the language we use and how we engage with families in a way that lets them feel like, you know what, they've got expertise too in this. And how do we pull that in? So it helps us kind of shift from that expertise power to facilitator with expertise. So that means that people do come to us on purpose. They call the IWK on purpose. They're looking for our expertise related to mental health care, and we're trying to join with them in understanding the expertise they have about their life experience and how we can together do some pretty amazing things related to their mental health goals. I'm including this image because sort of what I did here was kind of deconstruct CAPA. So sometimes people hear the label of CAPA and their minds can jump to particular things. Sometimes if you've heard people use it before, sometimes people go to the kind of mechanisms of CAPA as opposed to the spirit of the work. And so I have this slide because I think that CAPA rests on the two bottom qualities there of the spirit of quality improvement and shared decision-making approach. So what I mean by quality improvement is that idea that we're kind of curious about the work we do all the time. We reflect on that and think about ways that we can get better. So not thinking about, oh, I'm not doing a good enough job, but actually, how do we kind of shift our framework to think about, if I was to do something slightly different, what would be the impact for families? And how do we measure that and then know that we're moving closer towards excellence? So curiosity about our work is something that I love. A shared decision-making approach is really when decision-making is open, visible, and explicit, and that we're really being fully transparent so that the family understands what we're talking about and that they are joined with us in making decisions about what's important to them. Joint case formulation is kind of a unique thing for how we're particularly thinking about our first appointments, where we see in a choice appointment, which I'll talk about a little bit later. But that development of the case formulation ends up being that key hub from which all other things are going to come. So if we have a formulation and currently understanding what's happening, that lets us then be curious about what might be goals that are important to them related to their mental health or other areas of their life. And then that lets us then choose what might make the most sense to support them in reaching their goals, which you'll see as evidence-based treatments up there. And one of the really cool things about CAPA, which actually isn't captured in the slide, and I still need to think about how we do that, is that our active partnerships with our colleagues in the community-based services is really important. And part of our role at the IWK is helping families understand that maybe when their kids play sports or when they're involved in art-based activities or they're hanging out with friends, that in fact those activities in their communities are things that also can take them closer to the goals that are important to them and can have a very positive impact on their mental health. So it's not just what the system provides, it's what their whole community and their life experiences are that will take them closer to what's meaningful and important to them related to their mental health care. I understand that you've been provided with a copy of this open talk diagram. I really would encourage you on the bottom left-hand corner, you can see the directions to the website, which is called opentalk.info. And one of the cool things about this site is it was developed in collaboration between clinicians, adults, and youth who have access services. And it talks you through what really shared decision making can really be all about. So I love that on the top, the youth are sort of saying, talk with me about the decisions I have and how much input I can have on different elements. So part of transparency is letting people know, when do I have a choice and when do I not have a choice? So for instance, when it comes down to risk factors, your choices may be more limited, but it's important for clinicians to be transparent with youth about when that's going to happen. Thinking through options. So what are things that might work for me, and where might I find them? Talking about the pros and cons of the options available. So that's the red box. And in the slide, it's hard to read the text, but hopefully on your handout, you can kind of work through. These are kind of examples of questions that you might ask. And this spirit of shared decision making, in my mind, is something that crosses all teams in the mental health system at the IWK, because we're trying to be as open and transparent. Again, really thinking about how we ground ourselves in the family's experience of what it's like to come for care. Here we have a link to the choice appointment, and this video we're hoping to be able to show with you. And it came from ideas from clinicians actually who are noticing that often families were showing up for our first appointment in our outpatient teams, which is called a choice appointment, and they really weren't sure of what to expect. So that means that they really weren't that prepared. I've had experiences where youth show up and think, oh, I thought I was going to the dentist because my parents sort of joked me or cajoled me into coming. And that's not an awesome way to engage with families. So we created the video with clinicians' input and with youth input to try to create a way that families could watch the video. It's only 3 minutes long, and it helps orient them to what they can expect from our services. And we received very positive feedback from families when they watch it, because it kind of helps break down what they can expect and helps them kind of orient themselves in their thinking so that they're a bit more prepared coming in. This is a quote from Dr. Ann York, who's a psychiatrist and one of the CAPA developers. And it's one of the ones that kind of jumped out for me when we were in the process of choosing this model. You do not have to have a wait list. It can be eliminated. We need to stop talking about assessment and treatment as things that we do to people and talk instead about partnership and collaboration. And one of the things I like about this is it highlights one of the elements of the CAPA model, which is thinking about the language we use and how it reflects the way that people engage with us in our systems. So, although assessment and treatment is absolutely, these are essential elements to how we provide mental health care, we need to embrace them and understand what they mean. We're also thinking about how we help families understand that it's an active engagement or a partnership that we're going to be working with them when we are doing things that involve mental health treatment. And because it's all about behavior change, we have to find ways to be collaborative and really explicit in what the expectations are to think about how we help families engage in this process in a different kind of way. You may have noticed so far that I'm kind of talking about a philosophical or fundamental shift in how we think about care provision. So it kind of asks us to pause and think, hey, what's this system stuff all about? And if I'm part of the system, which I am, then how can I ask myself some hard questions about what is my own opinion about what the role of the family is in care? What's the role that I play in this arrangement or relationship that I'm going to engage with families in? As a system, what should we be thinking about as being our core business? So, what are the things that we do really well? And in fact, what are the things that we don't do and shouldn't be doing? And in fact, others do better. So, becoming much more comfortable and sort of sitting around that. And what is value added is another big question. So sometimes we create systems where there's lots of steps and they're complicated, but they're actually not that necessary for families. So how do we take a hard look at those and start to think about what are the essential elements that are really important to people and emphasize those ones? CAP is also about creating a collaborative practice stance. So that's the idea that we're enhancing task and therapeutic alliance. We're kind of when we work in a collaborative way, we're also improving engagement. And there's a lot of research to suggest that that collaborative stance would support to improve effectiveness as well as satisfaction with the kind of care. Earlier, I sort of said lots of mental health care involves behavior change. And so one of the things that we know to be important is how we work collaboratively with families helps families to understand much more specifically what's being asked of them and how it will be effective for them to engage in those processes and kind of be clear in what they're able to do at this point in time. Shared decision making is also a really important element. It ties back to the orange sheet, which I'm hoping you have in front of you and are taking a look at. But that really is kind of a more formal definition would be a consultative process. And it's where we're jointly making joint decisions about your healthcare, discussing options and benefits and harms, and also thinking about how the patient's values, preferences, and circumstances show up that inform the decision making. So it's one thing to make a decision in an office. Is that the same decision that they would make in their own home? So how do we think about the environments that they're coming in, the context that they're working in, and bring that expertise that they have about their lives to help inform decisions that we're going to make? You may be able to hear right now that the garbage truck is going through my neighborhood, and it kind of matches up right now with the bus ride metaphor. So, what I love about this image is the idea that the woman with the yellow hair gets to pretend she's the clinician or be the clinician, and we have our family here with kids, and I always kind of laugh that they let the dog drive the special bus, the London-based bus. And so the job of the clinician really is to join the ride that the family is on in terms of their life experiences. And as they stop at the mental health services bus stop, it's important to remember that the bus ride hasn't ever started at the IWK. People's lives existed far before they contacted us, and they have been on a journey together. And the bus ride isn't also going to stop at the IWK. It's going to keep on moving after their experience with us. So our role really is to think about how we get on the bus with the family. I mean, the top seat gives you a really lovely view and you get to join with a family perspective that they're taking. But sometimes we expect families to kind of join with us. And in CAPA, we're going to ask you to think about how do I join with the family's experience of care? Another key concept is thinking about a pull in different from a push approach. So, this is around how we kind of go into situations thinking about what's going to be just enough here that's going to be helpful for families. So, that's the idea that we're looking at the right dosage of treatment, the right amount that's going to make a difference. And sometimes we often think, I think our heads often go to making sure that people get as much as they need. But sometimes it's important to challenge our assumptions on that because sometimes too much can be as problematic as too little. So I think it's important that systems don't essentially pathologize people to say and suggest that they're going to need a whole lot when maybe we need to start in small steps and then continually increase along the way so that we have signs and indicators to know that maybe more is required or less is required. But we're being transparent, thinking about shared decision making, working towards goals, and thinking about what is it that's going to support them. Different from saying you have to take all these things in order to move forward, which would be more of a push system. Here's a metaphor. The idea of push, which we were just talking about, is that the milk is delivered every day, whether you need it or not. So this would be from areas that would have their milk delivered. Although now working in a pandemic environment, I've discovered you can get many things delivered to you. I used to also use the metaphor of the newspaper. So in my family, I have 3 boys, and we used to get a newspaper delivered every day. Whether we would read it or not, they often read the comics, they would fight over the sports section, but sometimes not everything was getting read. So that's the push. A pull system, so there's a pull system is different. So the milk in the push system, the milk is delivered every day, similar to what a newspaper would be like. And so the delivery rate really comes from the person that's giving you that. And you're not really indicating at that point whether you need it or not. In contrast, a pull system is when the family puts out a bottle when they need the milk. And so instead, that means that the family is signifying what they need and the rate is coming from the family. So a more modern metaphor again would also be that when I want to read the newspaper, maybe I'm going online now and finding what I need and kind of skipping over the sections that I maybe am less interested in. And so, or more frequently, we have been, say, ordering coffee online. And so now our coffee grounds are getting delivered to our house, but they don't just show up every single morning, although I might take a fresh cup of coffee delivered every single morning. But a pull system would be that we're calling or we're arranging something and then it's showing up. So that rate is coming from meeting the needs that I have at that time related to what's important to me. Another key concept that helps us in CAPA is thinking about flow. So we saw the bus earlier and that idea that the family is getting in the driver's seat. It's focusing on that family's experience of care. So we're joining the family in the process. Everything we do adds value to them. And again, that expertise becomes important in terms of how we work together to appreciate that they have a ride that they've already been on and we're joining with them in that. Value added is another concept that we do today. And value is something that we define in terms of what that experience is for the client and their family. So anything that maybe improves their health, well-being, and their experience. If you take it really far in some words, some people would say, is it something that they would pay for? So that maybe is a far extreme level of it, but it is important to think about, is this a thing that is so important to them that they would invest everything in it? And it would be important in terms of their health. And when you start to really break away all the extras, and we have a lot of extras in our systems often, the value starts to shine through a little bit more and you start to understand what are those key things that are required in order for us to make sure that the care we're delivering adds value to the family's experience and to the clients that we're serving. The tricky piece of all this is to maximize those value added parts and then eliminate the things that are kind of extra. The unnecessary waste, which can be kind of language that people don't like so much, but it's kind of thinking about what are those things that we do. Maybe our systems are really complicated and we've got multiple steps. Maybe our document processes is difficult, and we're trying to reduce those things so that we're able to, as staff and clinicians, invest the time in things that are important. And on the flip side is asking families and clients to invest their time in the things that are important to them. This slide is talking about a menu of options. So when you come to the IWK and our mental health system, we do have choices, but they're actually not unlimited choices. So we spend time thinking about what are the essential and important elements of care that we offer here. We work through establishing some important treatment goals when we're meeting with families and thinking about what is important to them. And then we start to talk about different ways that they might meet those goals, where that change agent that's going to support them to meet the goal is going to happen.
I'm used to handling everything by myself. It's easy to feel like nothing is going right, and it's getting really hard. Something needed to change.
We were having a lot of problems at home, and I didn't know how to handle what was going on with my son. We needed to do something to make a difference in my kid's mental health. And that's when I called Central Referral at the IWK and was booked for a choice appointment. It was a really big step for our family. We had moments where we felt like we wanted to back out because we weren't sure we were ready to have the tough conversations we needed to. But we took the risk.
I didn't really know what to expect. I thought they'd tell me I was crazy, or I'd see a psychiatrist who would give me all the answers. I thought I'd get some meds to fix me, but that's not what happened. Instead, they just talked to me.
A choice appointment is a conversation. We'll talk about what's going well in your life and what isn't so great. We'll talk about what you want to change, and we'll talk about options to get there.
They asked me some hard questions, but it gave me a lot of new things to think about, and I had time to decide what I wanted. It was okay. I started to realize that I was the most important part of my team. But I had a team, and I had myself.
A choice appointment is a step you can take to help you live the life you want to live. It can help you manage better and feel confident when you need to deal with something tough. The appointment is usually an hour long, and since we know that mental health isn't just about one person, it's helpful to bring a family member or someone who knows you well to your appointment. It's also okay to come alone. We'll talk about some of the different paths you could take. Some people might want to join a treatment group. Others might find help in their community if that's a better fit. You might work one-on-one with a clinician to explore taking some steps, even small ones, to reach your mental health goal. You might decide that coming to the appointment was enough. You may realize you already have the supports and resources you need.
They helped me figure out what was best for me and make a plan. I had a choice.
There's a lot you can do to get the most out of your choice appointment. Before you come, think about the goals you have. What are you hoping for from your appointment? What do you want to be different? And what do you want to stay the same? Notice what's working and what gets in the way if something is hard. If you made one small change today, what could it be? Coming in ready to talk about the answers to these questions can help a lot.
Like before my choice appointment, I thought about what happened on days when I felt good and days that I didn't. And with my clinician, we started to find patterns that helped me decide what I wanted to do next.
You know your life best, and you won't need us forever. A choice appointment might be all you need. A choice appointment could be a quick stop on your journey, or you might need the help of a mental health professional longer. Whatever the path you need, that's okay.
A choice appointment was our moment to talk, to plan, and to change. It was one step, and now it's up to us to keep moving together.
So the metaphor of a restaurant is kind of similar in that if I'm hungry, I'm going to go, in this example, looks like I've gone to McDonald's. And I have to think about, well, if I'm hungry, how hungry am I? And what am I going to need in order to feed my hunger? And so maybe one day, sandwich or a salad or a burger. But other days it's like the full meal deal and I need all pieces of that. And so it's really thinking about those different levels of intensity of care or different needs that would help to meet a treatment goal. Um, in this instance, it's our hunger goal. And thinking about how much do people need. So you don't want to have the full size super meal when actually all you needed fries was to meet that. So thinking much more purposefully about it. The other thing is that we have to become a bit more comfortable saying we don't do all things. So if you show up at McDonald's and you want to order a Whopper, they're going to say, sorry, we don't do that. You got to go down to Burger King. So we have to become comfortable also saying we don't do all things to all people for all different treatment options, and thinking instead about how we work and exist in a community where there are many, many options and being comfortable with what we here are able to do well. I want to talk you through a little bit about, this is a very simplified diagram of kind of what the experience is of coming and accessing care at the IWK. There are, of course, multiple pathways to come into services, but the one that many people take is coming through the central referral process. And at central referral, the family is able to make their own referrals to central referral themselves. So family physicians are able to make referrals. And when that happens, our central referral access navigators, the great team, contacts the family directly and talks to them about that referral. So we always have firsthand knowledge of the family's experience, and they gather that information using an evidence-based tool that we have there. And after that appointment, after that conversation, then the access navigator is making a decision about what next. So I'm realizing that there's all kinds of things popping up on your screen, and I'll talk you through them in a few minutes. So central referral might make the decision that the family meets our criteria for services at the IWK and our mental health, and they would get booked for a choice appointment in one of our 3 outpatient teams, Halifax, Sackville, or Dartmouth. And the nature of that conversation will then help inform based on the goals that families set, and their level of impairment will help us determine if they continue on in our IWK system or if there's a better fit for them. And so if it's decided that coming in to meet with a clinician will be a helpful option for them, then they would get booked for what we would call a core partnership appointment. And that's where we provide a lot of care for families for many people. Sometimes people need much more specific things. And in that case, then we would be working between a core and a specific approach. Sometimes specific might be even things like our intensive services or our specific care clinics. So there could be a variety of different things that might help to support the flow of care. And at each of these points along the way, there's options for families to then be exiting the formal system. So in central referral, our access navigators are going to be making a decision with the family informed by our criteria related to whether they meet our criteria. If they don't, then exiting is often a very helpful option for families when they know about new resources. So our central referral team does a great job supporting people to know about different things that might be actually a better fit for them. The same thing can happen in a choice appointment with a clinician when they're understanding what the family circumstances are. Sometimes options in the community can be a better fit than coming in to work at the IWK. So this pathway becomes really important to think about how we provide care for many people. In the choice appointment, which I referenced in the last slide, the appointment is kind of, I find them to be really exciting because they feel like a choose your own adventure in so many ways with a guide who's your clinician who has some expertise in understanding mental health and how things kind of fit together. And it means that the clinician is going to engage with the family in a way that really centers on curiosity, offering honest opinions about what things may be going on, considering the risk and the diagnosis of the child, thinking about how we develop a joint formulation together to understand how these things fit together, and then making an informed decision that guides us to a choice point. So once we have goals and we talk about different methods, then the family is making some decision about what next for them. And once we've decided what's next, we're also going to consider what could be things that they could do right now that could be important and meaningful to them that would help guide them through this process. And maybe these are different kinds of tasks or activities or looking up information on a website. All of these are ways that we engage with families so they don't have to think that they have to wait to come for care at the IDVK in order for change to be different. In fact, they can start doing things now that are important and meaningful and maybe just small, but could make a big difference for them. And so we have active conversations with the family about what they're prepared to do now and how that might be helpful. I think about how the spirit of this work that we've been just talking about can show up in a whole bunch of different ways. So we see individual staff that may be working in that kind of a way and thinking about that spirit of care. And then when we have a whole bunch of staff working together, we develop these strong teams and shared understanding of different ways that we work and appreciating the philosophy and stance can make a team stronger. And then within a particular service area, then you see even more optimizing of these kinds of values. And then when our whole system works together, the impact just grows and grows and grows. So we're really encouraging people from coming to the orientation is the more you're able to understand these philosophical stances of this approach to care will help us all embrace this way of working with families. I'm just referencing you back to the slide where we talked about a spirit of quality improvement, shared decision-making, joint case formulation, goal-based outcomes, and evidence-based treatment. I'm going to switch now and include a slide presentation that my colleagues Steve and Ann developed. They're the two that developed the CAPA model. And what I like about it is it kind of takes you through what it might be like for a family to come, particularly to one of our outpatient teams, and experience the flow of care that is built around a CAPA. So in this case, there's a referral that's received. The family has something going on that they're looking for help with, and they're wondering what should we do. So off they send or contact the referral place. In this image, you'll see that they're sending a mailed letter to Access Care. In our case, people would be calling. And I don't know anyone in our central referral system whose hair looks quite like this, but I'm sure they're all wearing bow ties every day. Once the referral is received, then it goes off to the appointment gets booked. And so in our system, as soon as the family is contacted, and we have a conversation with them about whether they fit within our system, then by the time they've hung up their phone, they already know when they're going to have a choice appointment and with whom they're going to be seeing. So we're trying to reduce the amount of worry or waiting that can happen. So that's an image of them having their booked appointment and the contact being happening. Booking into their, well, in this case, a paper diary, in our case, Outlook calendars. The choice appointment is selected and is booked, and the family then comes in for the appointment and they get to meet with their clinician. And that clinician is figuring out what it is that they want, understanding that knowledge to jointly form an understanding of their current situations, thinking about choosing what could be helpful for them, and then at that point, reaching a choice where we've talked about goals and then thinking about the methods for what could. In this case, the family has a goal that makes sense to come back and work with a clinician on. And so that the choice clinician is using their Outlook calendar to book an appointment to see their next step clinician for partnership. That's the woman with the yellow hair. And in the meantime, our clinician is going to think of different things with the family that could be helpful for them to do that will support them working closer to their. After the choice appointment, then the team gets together, and there you can see the choice clinician and the partnership clinician coming together. They're having their Wednesday morning conversation about what happened in that choice appointment. And that's the way that our teams grow stronger, when we're sharing our work and learning from each other and making sure that we're providing the best care possible. So now the family is coming for their first core partnership appointment. They're meeting with their clinician and they're thinking about how things have been. So this clinician is going to work from the information at the choice appointment. So we're working really hard so families don't have to continually tell their story over and over again. It's our job to get on that bus with the family and read about the information that they've done before. To think about those goals and the engagement tasks. So what worked well for them? What didn't work so well in that time period? And then agree on what will happen next. So what will be the particular interventions that will be supportive of them to reach their goals? And then things start. So our bus is back. The dog has got out of driving it. So that was a decision, except that I see the dog jump back in. Clinician got back on top of the bus, joined the family, and now they're starting their work together. In ongoing core partnership, they continue to work. And I'm going to argue that it's because they let the dog drive the bus and it was not the right person for the right job at the time, which is one of the mentoring or the models of CAPA. And so they've run into some problems. The clinician has a conversation with the family and has a conversation with their colleagues to think about what are the different options that we need to think about that will best support them. So part of a CAPA system is that the clinicians work together in smaller peer groups and have ongoing conversation about the work they do. And that allows to get better at the work. And it allows us to create and share about our knowledge and learn from each other. So maybe the care plan gets amended and they make some changes and someone is going to do a particular specific work with another clinician to add to the process. And that continues on in core partnership, and this might be specific partnership if that's required. Clinicians are going to make sure that they're communicating on an ongoing basis on what's happening and review with the family on the progress that's being made. And eventually those clinicians won't be needed in the same way anymore. And the family continues on. They found their dog and they're headed back into their community in what we call letting go. So this is their opportunity to practice the work that they're doing on their own and feel like they're pretty confident in what they're able to do. They've made some small changes or big changes, and those are significant in increasing their functioning and making their mental health care just a little bit better. So that concept of letting go is one of those states that's kind of unique to the CAPA model, in that we're thinking a lot about how we empower people and not assuming that people, we definitely know mental health, thinking about how we don't always make the assumption that they're going to require a high level of intensity of service all the time. And those that do, then we can be much more flexible and responsive to meet their needs. So this is our lion who's releasing people back into the wild That's one of the quotes from the Kappa developers, is this idea that we support people to get back into what they were doing before. Knowing that they've learned, knowing that they have new skills, and being mindful of the work that they're going to do and generalizing that into their lives. I truly believe that when we're all embracing these kinds of philosophical stance that Kappa embodies, that as a system of care, we'll be stronger together, and that the family's experience of care is going to carry them forward in a way that makes much more sense for them and they can get on with living. Thank you today for in this conversation. I hope that there's some inspiration. I'm sorry to not meet with you in person, and I always love to learn new ideas. So if you've watched this and something's popped into your head, or you've come from a different system where something worked really well, we're always wanting to learn and get better at the IWK and our mental health and addictions program. You will inspire us. We hope you're inspired by us, and welcome to the team.